This week, we're starting the chapter discussing the problem of cardiovascular disease. That's Chapter 4 in your textbook, 3rd edition. In this lecture, we're going to talk about the prevalence of cardiovascular disease. We're going to talk about the risks and how to assess cardiovascular disease. But it's also important before we begin to realize that what we eat does matter on the long term. For indeed, a lot of cardiovascular disease problems in our nation, in fact, what is really the driving force behind this epidemic is the quality of our food. There are currently 178.6 million Americans suffering from at least one risk factor of cardiovascular disease. This represents 47% of the U.S. population. So between 2003 and 2014, cardiovascular disease cost approximately $132 billion per year in direct and indirect costs and represented a total of about 670,000 reported deaths in 2020. In fact, according to the NIH, it's the leading cause of death in the United States for both men and women. Let's take a closer look at the causes of cardiovascular disease. First, poor diet and lifestyle. So in this particular lecture, I'd like the students to know the American Heart Association guidelines. I want them to know the DASH dietary guidelines, and I want them also to know the TLC guidelines. So there are tables in the textbook, and it's important for students to memorize these guidelines. There aren't many, but there are some slight differences between the guidelines, and students should be able to distinguish between the two. So I encourage students, of course, to memorize these very short tables. There's also abnormal lipid metabolism that is very relevant in the understanding of this disease. Consequently, it's important for students to know, for instance, how chylomicrons are formed, how the VLDL and LDL cholesterols are formed, and how the HDLs are formed, and how atheromas are formed, and what the consequences are of these atheromas. So the first concept of assessment is realizing that 34% of adult Americans actually suffer from a condition called metabolic syndrome. What is it exactly? It's patients with 3 or more symptoms. What are the symptoms to select from? A fasting blood glucose greater than 100 milligrams per deciliter, an HDL cholesterol less than 40 in men and less than 50 in women, serum triglyceride greater or equal to 150 milligrams per deciliter, a waist circumference greater or equal to 102 centimeters in men, that's 40 inches, or greater or equal to 35 inches or 88 centimeters in women. And then finally, a blood pressure of equal to or greater than 130 per 85 millimeters. Now, so the patient that has metabolic syndrome will have 3 symptoms among these situated here. It's important for students to have these particular conditions memorized so that they can easily recognize them in their assessment of the case reports or the cases that we're going to be looking at. So it's fundamental in our understanding of cardiovascular disease that we have a really in-depth understanding of lipid metabolism, or in other words, in the metabolism of fat. Specifically, what we're going to look at is the fat in the blood and how this ultimately translates into risk for the patient. In the end, the student should therefore have a better understanding of what we call lipid profiles of patients. I want to start the discussion at the point of entry of food. As we consume our food, what essentially happens to the fat component is what we're going to be focusing on to understand how the lipid profile of this particular individual then develops afterwards. Once the food enters the mouth, it travels along the gastrointestinal tract and it makes its way into the intestine. And here we see the villi that actually coat the lining of the intestine. And enzymes are going to attack the fat component, notably lipase, and the lipase is going to begin to break down the lipid components, the long chain fatty acids, and so forth, into smaller components. And these smaller components are going to enter the enterocytes, which are individual cells that line the outskirts, or the outline, if you will, of each individual villi. Once these lipid components are inside the enterocyte, they get encapsulated within a large lipoprotein called the chylomicron. And the chylomicron then is actually secreted into the lymphatic system, and from the lymphatic system it moves into portal circulation, and it's right here that we now identify the chylomicron. The chylomicron then circulates in the blood and deposits the FFA, the free fatty acids, into adipose tissue and also into peripheral tissue, noting vascular lining and muscle tissue and so forth. And as it gets rid of its payload, it progressively becomes a chylomicron remnant, meaning the remaining component after the main payload has been dispensed to the various tissues. It then, follow the arrow, moves as a chylomicron back all the way to the liver, where it's broken down and the remaining lipid components, which are again free fatty acids and phospholipids and cholesterol, are re-encapsulated into a brand new set of smaller lipoproteins called the VLDLs, or the very light density lipoproteins. As the VLDL gets rid of its payload, which is primarily triglyceride, the free fatty acids and the triglyceride get deposited in adipose tissue and peripheral tissue, and then it becomes ultimately an intermediary density lipoprotein, or an IDL. And as it continues to get rid of some payload, it becomes LDL, light density lipoprotein, and it's the LDL that we identify as the sort of bad cholesterol in the blood and an indicator of cardiovascular risk. I want to go back now and review this process, but add a little bit more detail. I want to pick up after the food has been broken down by the lipase enzyme and other enzymes that are relevant, and the food component, notably the lipids, have been sufficiently broken down to be absorbed into the cells surrounding the villi, and we call these the enterocytes, and we identify them here. You can see the little wavy finger villi, or microvilli, that we see here along the enterocytes. So these are not villi, but the microvilli. And the enterocytes are really the major cells that are lining the villi. And what we're noticing here is that there is a movement across the microvilli into the enterocyte of the glycerol, the SCFA, short-chain fatty acids, the MCFA, the medium-chain fatty acids, and a little below, the LCFA, the long-chain fatty acids. So what do we note here? Well, we note that the short-chain fatty acids and medium-chain fatty acids move into the enterocyte, and from the enterocyte into the circulation without having to be encapsulated within any kind of lipoprotein. It is also notable that the medium-chain fatty acids, along with the LCFA, the long-chain fatty acids, make their way also through the microvilli into the enterocyte, but in this case, they actually get encapsulated within this lipoprotein marked here with a C and a purple ring around it. This is the chylomicron. So both medium-chain fatty acids will go through without a lipoprotein. We saw that up above. But we'll also note that some medium chain fatty acids, along with long chain fatty acids, will get encapsulated into the chylomicron. And then the chylomicron makes its way into the yellow bar, which is the lymphatic system. And this lymphatic system eventually merges with the portal circulation, which is in fact part of the vascular circulation, or identified here on the graph as VC. So I'd like to try again and review this lipid metabolism, this time adding just a few more details, but hopefully in this revision, the fluidity of the different steps will be more recognizable to the student. So we begin our discussion on the left in the intestine, the dietary lipids, and here we see the chylomicron, a large lipoprotein. So we can see in size that it's the largest of the lipoprotein, and we know that in terms of its makeup, it is mostly made up of triglycerides with a few inserts of cholesterol and some phospholipids. Now, this is where the dietary fat that has moved into the enterocyte gets encapsulated. And once it's encapsulated, it moves through the lymphatic system first and then into portal circulation. And we can see that as it is moving along portal circulation, in the vicinity of what we call the peripheral tissue, it's going to be dropping its payload, primarily triglycerides, into the muscle, adipocytes, and vascular endothelium. As it gets rid of its payload, we can see the large round lipoprotein diminish in size, and we can see it going back to the liver in the form of a chylomicron remnant. You can observe now that once in the liver, the triglycerols, cholesterol, the esters get reencapsulated into a VLDL, and that goes out into circulation. And as it drops its payload into muscle, adipocyte, and vascular endothelium, it becomes an intermediary density lipoprotein, IDL, and eventually it becomes an LDL as it continues to drop its payload. The IDL and LDL eventually end up going back to the liver, where the components of these lipoproteins get reprocessed in the liver and re-encapsulated again into a VLDL, and it recirculates. Now I'm newly introducing the HDL, defined on the far right as a high-density lipoprotein. Unlike the LDL, the HDL is considered the good cholesterol, and it is coming from the peripheral tissues, capturing the cholesterol and bringing it back to the liver. So it's regarded as a scavenger. So it scavenges cholesterol that's found in the peripheral circulation. It re-encapsulates it inside the HDL and it brings it back. So this really means that when the HDL levels are elevated, it means that there's a high amount of this particular lipoprotein actively taking away the cholesterol from circulation in peripheral areas and bringing it back to the liver. So then in that sense, elevated HDLs are a positive, good indicator of low cardiovascular risk. Now I want to focus on the composition of the different lipoproteins, and that will help better refine your understanding of the whole metabolic pathway. So we begin the discussion at the top by looking at the chylomicron and seeing the different components first that are making up this chylomicron. We're noticing triglycerides, we're noticing cholesterol, we're noticing cholesterol esters, and phospholipids. Now we know on the right, for instance, that the white bar is indicative of the triglycerides, and this is what I want you to focus on. The chylomicron is made up of 82% triglyceride, and you can see on the bar on the right hand side that there's virtually very small amounts of dietary cholesterol. Now, the next one in line is the VLDL. And if you remember, the VLDL is what re-encapsulates the components, the remnant components of the chylomicron remnant. So it does this in the liver and recirculates it into peripheral circulation. As it drops its payload, which is mostly triglyceride, we can see the triglyceride component decrease to 31% in the IDL, and we can see proportionally that the cholesterol increases from 22 to 29%. By the time it becomes an LDL, triglycerides only represent 9%, and you can see proportionally that there is well over 40% of the LDL made up of cholesterol. So when the physician picks up on elevated LDLs in a patient, he's really picking up on a lipoprotein that contains a lot of cholesterol. And this is what has historically been regarded as a risk factor for cardiovascular disease. Now, down below, you can see the HDL, the high density lipoprotein. 50% of this particular lipoprotein is actually made up of cholesterol, and you can see that virtually an inexistent amount of triglyceride in this particular lipoprotein. So remember, the HDL is the scavenger, so it's actually bringing the cholesterol back to the liver. So when the LDL levels are elevated in the blood, it increases the risk of cardiovascular disease and notably atherosclerosis, or the building up of atheromas in the blood, as we see here. The graph at the top shows a non-diseased vascular system in which the circulation of the blood moves freely. And then in the second one just below, you can see the buildup of an atheroma, which takes place in the inner wall of the artery or vascular system. So this buildup is taking place because of deposits of cholesterol and also accumulation of foam cells derived from essentially white blood cells that are broken down and so forth. And this accumulates within the wall as an atheroma. The one below shows that ultimately this atheroma can then occlude or block the circulation, causing a heart attack. One theory behind the causes of atherosclerosis is essentially the damage to the lining of the blood vessels, leading to plaque formation. So let's take a look at what could initiate these kinds of damages. Well, first of all, it begins certainly with high levels of circulating LDL cholesterol, which you now can identify as the bad cholesterol. But there's also high circulation of free radicals, which are byproducts of oxidative stress. So the more oxidative stress in circulation, of free radicals. And this will occur, for instance, in smokers, individuals that take drugs, people who are under stress, create these byproducts of metabolism, and the increase in number, the more this sort of physiological stress takes place on the body. And so we see these high circulating free radicals, which are the byproducts of oxidation. And these free radicals attack the integrity of cells, and they can damage cells. And so with this kind of a damage, then the risk of some sort of plaque formation increases. Now, free radicals don't just do this damage on a short term, but usually it takes 15 to 25 years of persistent stress of this kind, such as smoking, excessive drinking, and so forth, that brings on these free radicals and does this oxidative stress and damage ultimately to the cells. We know that this high circulating free radical, in combination with a low antioxidant status, and this low antioxidant status really is tied to diet. So if you don't have antioxidants in your diet by not eating, for example, a lot of fruit and vegetables, then you'll have an inability to counter the free radicals. So indeed, If you've got high circulating free radicals, you need to have high levels of antioxidants. Having hypertension is also a pretty high risk factor because it means the blood is pumped through the vascular system at a higher pressure, and therefore, if there is a hardening of the arteries, this could create also some damage to the lining. But also, if there is already damage, say through the effects of the free radicals, the hypertension will simply worsen it. The toxins from cigarettes will actually have an effect of hardening the arteries and creating damage. And one of the signs biochemically that this is actually taking place and that there's a higher level of risk is elevated homocysteine. In fact, when elevated homocysteine levels are observed, it's an independent risk factor for cardiovascular. So when serum homocysteine levels are elevated, it's considered an independent risk factor for cardiovascular disease. And this is because biochemically, high levels of homocysteine are tied to low levels of vitamin B6, B12, and folic acid. Some experts in the field put the emphasis on the folic acid because folic acid is found primarily naturally, that is, in fruits and vegetables. So if the homocysteine levels are elevated, it could be an indication that there is low-level fruit and vegetable in the diet. What's interesting is by giving folic acid, B6, and B12 to the individual and normalizing homocysteine, it does not reduce the risk of cardiovascular disease. So then in that sense, the high levels of homocysteine really act as a surrogate for poor nutrition. So in summary, once there is damage to the cardiovascular lining, this is what ignites the risk of then developing an atheroma. So there are particular strategies to control cardiovascular disease. The first is to follow the DASH diet and know this diet well. It's in the table found in your textbook. I encourage students to memorize it because it will help you to resolve problems more quickly. The same thing applies for the therapeutic lifestyle change, TLC. There's a table also in the textbook. I encourage you to consult it and to learn it by heart so that you know it well, and this will be very helpful to you when you do the quizzes. You'll note that in the DASH diet, there is a greater restriction of total fat. It's less or equal to 27% of total calories. And you'll note that in the TLC diet, it's much more generous, 25 to 35%. So when you're thinking about patients that need a severe restriction, need to see results at the blood lipid level, the DASH diet is probably more appropriate. Now I want to draw you to table 4.2 and consider the different classifications of LDL cholesterol, total cholesterol, and HDL cholesterol. So minimally, students should know what the optimal healthy level of LDL cholesterol is in milligrams per deciliter. So indicated in table 4.2, that's less than 100 milligrams per deciliter. They should know what is considered borderline, 130 to 159, what's considered high, 160 to 189, and what's considered very high, equal to or greater than 190. This is the LDL cholesterol. For total cholesterol, they need to know what the desirable level should be. That's 200. And what's considered borderline and high. The HDL cholesterol, they should know minimally that for men it should be equal to or greater than 40 milligrams per deciliter, and for women equal to or greater than 50. And for those that are searching for the ideal that is very protective against heart disease, then it should be equal to or greater than 60 for both men and women. The triglycerides are also very important, right? So the ideal, of course, is to keep them under 150. And then students should know what high is and what very high is. So I recommend that students practice these probably with each other. Use your roommate, use your parents, and try to memorize these critical cutoffs because you'll be asked to use them in specific cases that we're going to be seeing in the classroom or ultimately the online classroom. And you should be able to quickly come to a resolution of whether or not the patient has high cholesterol or borderline cholesterol or triglycerides for that fact. So now I'd like to look at a practical application of how the DASH diet can be applied. So in this particular case, a man has DRI calories of 3,450 calories per day, so that's his requirement. And so the student should be able, after having memorized the various components of the DASH diet, should be able to construct a DASH diet indicating the following dietary parameters that they would prescribe. And so in this case, we're looking at carbohydrates, proteins, fat, saturated fat, cholesterol, sodium, magnesium, calcium, potassium, and fiber. So really, this is strictly a memorization process and then a calculation process. So stop the video here, and hopefully after having memorized the DASH diet, you can now systematically go through and establish the quantities that can be assigned to these various dietary components. So, having memorized the DASH diet, you would know that 55% of the calories are carbohydrates. So that's 474 grams. And then 18% of those calories are protein. So that's 155 grams. And then 27% would be equal to 103 grams. So note the percentages: 55 plus 18, that's 73, plus 27 equals 100. Now, saturated fat, the cutoff there is 6% or less. So 19 grams, if you calculate that, is actually equal to 4.9 or 5% of the DRI. So that is indeed a correct saturated fat amount to teach a patient. And then the cholesterol is less than 150, so significantly more restrictive than what we see just with healthy eating guidelines. Sodium less than 1500, again much more severe than the 2400 milligrams that we see as an upper cutoff level. So this is much more stringent. Magnesium at 500, and magnesium is very important because it acts, it would appear, with calcium, potassium in diminishing overall risk of heart disease or of hypertension specifically. The calcium at 1,250, potassium at 4,700, and fiber is definitely even higher than the FDA's requirements here, so that's 30 grams per day. So this would be an application, an example of an application of how using the memory of the DASH diet table that you could apply it to an individual who has a specific caloric quantity, who presumably is at cardiovascular risk. Well, now I'm going to refer students to table 4.3 for the TLC diet. And here again, I encourage students to memorize this. This is not difficult. And then apply it to this particular case, which is very similar, a 3,400 kilocalorie a day. And here you are to construct a TLC diet based on these particular parameters. So pause the video here and do your calculations. Let's examine the calculation. So for carbohydrates, the range indicates 50 to 60. So this is different than the recommended macronutrient ranges for healthy eating, right? This is specifically the TLC diet. So it is different, and it's good that students remember this. So it's 50 to 60%. So in this case, the 55% was allotted. So 55% of 3450 gives you 1896, and then divide that by 4, that's 474. Then protein should be 15%, And so at 15%, that's 516 calories. That's divided by 429. And of course, what's left over is 30%. So fat at 30%, and that's perfectly consistent with the guidelines here, which are 25 to 35. So again, different than the macronutrient recommendations for healthy eating, which are 20 to 35. The TLC is 25 to 35. So good to keep that distinction. And then the saturated fat is less than 7%. So saturated fat at 19 grams, you can calculate that. That's less than 7%. The polyunsaturated fat is up to 10%. So at 19 grams, why don't you pause here and do that calculation as well, right? That's 19% is essentially 19 times 9, because it's a fat, is 171 calories, right? Divided by 3450, and that gives you 5%. So really, certainly within 5 to 10%, but not exceeding 10%. Then the monounsaturated fat is up to 20%. And we can say minimally, from what we know from our previous guidelines, that it should be 11% or more. But now we're learning that a maximum of 20% is probably appropriate. So 11% right up until 20% of calories. So the monounsaturated fat at 77 grams times 9, which gives us 693. Divide that by 3450, and it gives us exactly 20%. So we're good. And then the cholesterol, this amount is less than 200 milligrams, so it's not as severe as the DASH diet. And the fiber is here quite similar, 20 to 30 grams. And so there's a little bit of a range there, and 30 grams is within that range. So this, in fact, meets a good application, good practical application of the TLC diet to a specific individual with a specific amount of calorie requirement. So it's good that you become able to execute these kinds of problems. So now I want to look at the case study that's found in your textbook, page 109. This is section 4.5. So you can follow along. I'm going to give you the sort of summary findings of the case and hopefully an acceptable conclusion. So again, I invite you to follow along in the book. So this is a 45-year-old male who presents with early hypertension and hypercholesterolemia. Body weight's 183 pounds. The height is 5'9". And in our history, we find out the patient gained about 20 pounds in the last year. He works out at the YMCA 3 times a week for about 1 hour and a half. So in our assessment of the diet, so look it over in the book, he eats more in restaurants because of more business travel. So that implies a lot of fat, a lot of sugar and salt, a lot of processing. He drinks more beer and wine at meals because of the traveling. Otherwise, meals are balanced according to the Choose My Plate guidelines. What about the body composition assessment? Well, we learned from our calculations and from what is reported in the history that the usual BMI is 24, and that with the 20-pound weight gain, his current BMI is 27. This puts him at overweight. His waist circumference, we learn, is 41 inches. This should set off some alarm bells because, again, for men, the waistline should be less than or equal to 40 inches, so he's a little bit above. Medical assessment, he's got hypertension with 138 over 87. His LDL, if you memorize table 4.2, at 135 milligrams would have him at a borderline elevated LDL. So you should be able to determine that just visually without consulting your book. The HDL appears to be okay at 48, and we know that for men, the HDL should be equal to or greater than 40. So at 48, he passes the test. And his triglycerides ideally should be under 150, so everyone should know that. So at 179, they are borderline elevated, right? And so students should be able to determine that just by visualizing it. So again, go back to table 4.2 and make sure you memorize that table. So based on the information and the assessment from the textbook, what would you be willing to recommend? Well, possibly weight loss is recommended, about 18 pounds, which would represent a 10% drop in his weight, which is sufficient, according to the literature, to decrease his blood pressure. The weight loss should be experienced, we would recommend over 40 weeks at a rate of a half a pound per week. So remember, you generally don't want to be exceeding from caloric restriction alone more than a pound a week of weight loss. Now, exercise should be recommended according to physical activity guidelines for Americans. 150 to 100 to 300 minutes a week, spread over that period of time using aerobic and muscle strengthening exercises. So the diet prescription, definitely a decrease in alcohol drinks to 1 per meal. Probably as a general guideline without having to put that person on an arduous dietary limitation, because it looks like he's eating well at home. So we just want to say, perhaps as a visual guideline, consume only 75% of the plate at the restaurant. So walk away with still some food on the we would encourage the patient to continue eating healthy meals, because it looks like the problem is when he's basically traveling. But at home, it looks like the diet is well balanced. If the cholesterol does not decline with this simple approach, then consider decreasing the consumption of meat and encouraging rather the intake of fish and plant-based proteins to see whether or not the cholesterol profile can change appropriately. So, of course, in applying this particular prescription, the student should be able to establish the goal weight and establish an appropriate body fat percent to essentially achieve. And then looking at the amount of calories through diet restriction that could be achieved, and probably working in some energy expenditure from exercise, so some kind of a routine from exercise that would represent a certain caloric expenditure per week, which could complement the half a pound of weight loss per week to probably maybe about 1.5 pounds to ultimately 2 pounds per week, diet and exercise combined. All right, let's consider case 2. This is a 38-year-old heart attack patient. The case is well described in section 4.6 in your textbook, page 110 of the second edition. What do we know about this case? Well, this is a male, 38-year-old pharmaceutical representative, a family history of heart attacks. He suffered a heart attack 5 weeks ago while doing some home repairs. He underwent bypass surgery 2 weeks ago and is now considered stable. Patient lost 49 pounds since the heart attack. What do we know about the medical assessment? The body weight, 256 pounds, height 5'11". His usual body weight prior to the MI, or the myocardial infarction, was 305 pounds. When looking at his triglycerides, they were elevated. When looking at blood sugars, values suggested type 2 diabetes, and he had high blood pressure. The dietitian does a body composition assessment and finds that there's 47% body fat. The waist circumference is 56 inches, and the body mass index is 35.75, which puts him in the category of obese class 2. Now refer back here to chapter 2 or chapter 3 of body composition. What do we know about the lifestyle assessment? Well, he travels extensively in his work. He has low to mild activity level. He eats in restaurants extensively. His energy needs, according to height, body weight, age, and physical activity, is 3,713 calories. So he's a big man and requires quite a few calories. His diet assessment prior to the heart attack indicated that he was consuming 6,700 calories a day. The fat intake that he was experiencing represented 77.6% of the DRI calories, or 44.3% of his actual caloric intake. So, in other words, 44.3% of his 6,700 calories. His total sugar intake was excessive. It was far beyond the 20% DRI calories, and that's the cutoff, so he's well beyond that. His total carbohydrates were also excessive because they were over the 65% cutoff, which is the upper cutoff for the recommended macronutrient ranges for carbohydrate. Well, the next step, of course, is the diet prescription. So, what are we going to prescribe for this patient? Well, it'd probably be wise and reasonable to prescribe a DASH diet, which would be taught to the patient. The goal would then be to begin a weight maintenance diet using a low activity factor. So remember, he's just had a heart attack, so we want to stabilize his weight. Fear drives this man's relationship with food. So, after a heart attack, a lot of individuals have a fear of food. The goal is to provide him with safe food selections that will keep him healthy. One principle in good diet prescription is to increase the fiber. He's relatively low now. In the description of his diet, he's consuming 6.92 calories per thousand kilo, or 6.92 grams per thousand calories. So we want to be able to bring that up and meet the recommendations. And then the next step would be to determine the total patient's expenditure for weight stability. So we would use the Garrier equation. You could also use Mifflin, but in this example, I'm using the Garrier equation, and I'm providing this man with a mild activity factor. So if you go back to your tables for the Garrier, and you'll find that over in page, table 2.5, page 58. And so we're looking at a mild activity for a male. That would be a 1.12 physical activity, or PA. So in this particular case, then, we would establish what his total energy requirements were. So using the cheat sheet, you would see what the total energy expenditure, the TEE, is for this particular male using the Garrier equation. So here we'll end up adding, several of the factors. First, he's 38 years of age, so 38 times 9.72, and that will subtract 864. His activity factor is 1.12. His weight that is his current weight after the heart attack, is 116.22 kilograms. That multiplies 14.2, and his height is 1.803 times 503. So now the 1.12, if you notice, will multiply the addition of weight and height together. So we get, first, from the age adjustment of 864 minus 9.72 times the age, we should get 494.64. That then gets added to the combination of 1.12 times the weight and height factor, which is 2,556.91, and so we add those together and we get 3,052 calories. So the requirement for this particular patient for weight maintenance is 3,052. So now, once the TEE is established, then the student is expected to be able to apply the DASH or the TLC diet, so see the appropriate tables and do the appropriate calculations. So this is what would be expected in the prescription of the diet. After the patient's weight is stabilized and that new and healthy dietary habits are practiced more regularly, a slow weight loss from a diet restriction of about a half a pound a week can be recommended along with exercise, which should consist of about 500 calories a day in exercise above normal, or 3,500 calories per week. In other words, 500 calories a day would be translated into 3,500. How do we get that? 500 times 7, right? So from exercise alone, that person would be losing 1 pound, and from diet, a half a pound a week. So for a total then of 1.5 pounds a week. And from this calculation, then the student should be able to determine how long it would take this patient to lose the weight in question. So in this case, we should be aiming for a caloric restriction that will allow a half a pound of weight loss per week. So since 1 pound weight loss is equal to 3,500 calorie deficit, then a half a pound would be equivalent to 1,750 calories over 1 week, or the equivalent of 250 calorie deficit per day. In other words, 1,750 divided by 7. So the diet prescription for weight loss would be 2,802 calories a day, or essentially the DRI calories that we established in the previous slides minus 250. Now, regular exercise routine now is important to complement this dietary restriction. So, for example, we could prescribe walking at 3 miles per hour for 2 hours a day, 3 times per week, based on the current weight of 256 pounds. He would expend a total of 768 calories per 2-hour walk. So this is calculated by taking his body weight of 256 pounds and multiplying it by the walking expenditure standard that we see on the left-hand side. So walking at 3 miles per hour would expend 0.025 calories per pound per minute. So now we take his body weight, 256, we multiply it by 0.205, and we get the number of calories per minute, and then we multiply that by the number of minutes, which is 2 hours or 120 minutes, and we get 768 calories for every 2-hour walk. Now, since he's walking 3 times per week, we multiply the 768 by 3, and we get 2,304 calories. So his total weekly expenditure, or deficit if you will, need to be rounded out to a daily deficit. So 1,750 calories a day for the diet restriction, and 2,304 calories, and all this divided by 7, because if you remember, what we did up here was per week. So now we've added the weekly calories, 1,750, 2,304, and we divide all that by 7, and we get this equivalent of a 579 calorie a day deficit. So now, in terms of completing the diet prescription, we determine this total weekly loss of 579, and we can then determine the rate of weight loss. So if a pound of weight loss is 3,500 calorie deficit, then 4,053, which was calculated by taking the daily deficit times 7 days, so we get a weekly deficit of 4,053. We can determine how many pounds equivalent that this represents in terms of a weekly loss. So that's 4,053 divided by 3,500, and you get a pound, 1.16 pounds more precisely, of weight loss per week. And then with this, you're able to determine how long it would take, for instance, to lose 60 pounds. So I invite the student now to complete this mini training quiz that will allow them to more precisely refine their thinking and their calculations pertaining to obesity. First question, identify the optimal level of LDL cholesterol. Optimal meaning the healthy level that a patient should aim for. The correct answer is less than 100 milligrams per deciliter. Next question, identify the LDL cholesterol range that is considered borderline high. The correct answer is 130 to 159 milligrams per deciliter. Next question, identify the LDL cholesterol range considered to be high. The correct answer is D, 160 to 189 milligrams per deciliter. Next question, what is the triglyceride cutoff for which values are considered high? The correct answer is B, values equal to or greater than 150 milligrams per deciliter. Next question, what is considered an optimal healthy HDL cutoff for men? The correct answer is D, greater or equal to 60 milligrams per deciliter. In fact, the optimal for both men and women is over or equal to 60 milligrams per deciliter. But in terms of meeting minimal requirements, it's important that for men, it would be equal to or greater than 40 milligrams per deciliter, and for women, equal or greater than 50 milligrams per deciliter. So certainly equal or greater than 60 is optimal. So please refer back to table 4.2 in the textbook for these particular guidelines. Next question, what is the HDL cutoff for women below which they are at high risk of heart disease? The correct answer is less than 50 milligrams per deciliter. This is truly the ideal, is to get over 50 milligrams per deciliter for women. Next question. A man requiring 3,300 calories per day is prescribed a DASH diet for hypertension. Identify below the total fat cutoff that will be prescribed for this patient. The correct answer is less than or equal to 27% of the DRI calories. A man requiring 3,300 calories a day is prescribed the DASH diet for hypertension. Identify below the saturated fat cutoff that will be prescribed for this patient. The correct answer is less than or equal to 22 grams per day. This was reached as an answer by using the cutoff of less than or equal to 6% of the DRI calories. So that's 6% of 3,300 calories divided by 9, because there are 9 calories per gram of fat. Next question, a patient is prescribed a TLC diet for the management of heart disease. If his DRI calories are equal to 2,870 calories per day, identify below the most accurate protein intake he'll be prescribed. Well, the correct answer is 108 grams per day. This was calculated using 15% of 2,870 calories. Next question, a patient is prescribed a TLC diet for the management of heart disease. If his DRI calories is 2,870 calories per day, identify below the range of carbohydrates he could possibly be prescribed. The correct answer is D, 359 to 430. That's using 50 to 60% of the DRI calories. The final question, a 45-year-old man weighing 195 pounds with a height of 5 feet 10 inches, who's considered active, that's an activity factor of 1.27, would have DRI calories equal to what value if calculated using the Garrier equation? So for this, students should have their cheat sheets ready to compile or calculate this equation. The correct answer is C, 3,160 calories per day. I would encourage students to contact their professor if they're having difficulties with the last calculation using the Garrier equation, or if they're still struggling with the Mifflin equation. Now we're going to do a bit of a quiz using critical thinking. All right, first question. A patient presents with a blood LDL cholesterol of 135 milligrams. What do you conclude? Pause here, think about it, and select the correct answer. Because the LDL cholesterol is between 130 and 159, the patient is considered borderline high. Next question. A male patient presents with an HDL cholesterol of 38 milligrams per deciliter. What do you conclude? Pause here and select your answer. Because the patient is under 40 milligrams per deciliter, he is considered B, low. Next question. A female patient weighing 246 pounds with a height of 5 foot 2 inches presents with a triglyceride of 149 milligrams per deciliter. Blood pressure is 138/92. The fasting blood sugar is 93. The waist circumference is 38. And the HDL is 52 milligrams per deciliter. What would you conclude about this patient? So first, you should think about calculating his BMI. If you do his BMI, you'll find that he has a BMI of 45. This BMI of 45 means that he is certainly morbidly obese because he's over 40. His triglycerides are okay because they're under 150 milligrams per deciliter. If we look at his blood pressure, his systolic blood pressure is over 130 and his diastolic is over 85. So we could categorize him as hypertensive. His waist circumference is 38 inches. So this is actually under the 40 inches that's recommended. And the HDL is 52, which is ideal for this patient. First question to ask is, does he have 3 of the factors that identify metabolic syndrome? Look for the definition in your textbook. Well, certainly it doesn't look like it. His triglycerides are okay, his waist circumference is okay, his blood sugars are okay, his HDL is actually okay. So we can only conclude that this is a morbidly obese patient with hypertension. Next question. A 45-year-old woman weighing 270 pounds with a height of 5 feet 4 inches presents with a body fat of 38%. She has a waist circumference of 42 inches. Her blood pressure is 136, or blood sugar, sorry, is 136 milligrams per deciliter. Her LDL cholesterol is 165. Her triglyceride is 178. What would you conclude? Pause here, investigate, and select your correct answer. Looking at the whole of the data for this woman, we can say using her BMI that she is certainly obese, and the body fat measurement at 38% is certainly over fat. Waist circumference at 42 inches is over the 35 for women, so that's one factor of metabolic syndrome. Blood sugar is over 110. That's a second factor leading to metabolic syndrome. And triglyceride is over 150. That's a third factor for metabolic syndrome. And then if we look at the LDL at 165, certainly that makes her hyperlipidemic. So the correct answer on this one would be B. She's metabolic syndrome, hyperlipidemic, obese, and overfat. Next question. Identify below the DASH diet recommended cutoff for saturated fat for a person requiring 2,400 kilocalories a day. So the correct answer is calculated by using 6%, so it's 0.06 times 2450, divide that by 9, and the correct answer is less or equal to 16 grams. Next question. In recommending the TLC diet for a woman requiring 2,789 calories a day, what would be the maximum amount of fat allowed in her diet? Pause here, do the calculation, and select your answer. The correct answer is D, 108 grams. This is calculated from the basic recommended range for total fat, which is 25 to 35% of calories. So the maximum amount here is 35%. So that's 0.35 times 2789. Divide that by 9 and you get your answer. The last question. A patient weighing 340 pounds has a DRI calorie established at 3,678 calories a day. He's hypertensive, so the doctor prescribes a TLC diet. Identify the diet below that most closely resembles the TLC guidelines. Pause here, do your calculations, and select the right answer. So at this point, you should be able to rhyme off the key guidelines for carbs, for MUFAs, which are monounsaturated fat, for polyunsaturated fats, for total fat and cholesterol. For carbohydrates, for instance, the guidelines are between 50 and 60. For monounsaturated fats, right up till 20%, but you also know that they should be 11% up to 20%. Polyunsaturated fats, really a maximum of up to 10%, but it's really 5 to 10% that we've learned earlier. The total fat is 25 to 35, and the cholesterol should be less than 200. So now let's begin with our calculation. So if you take 414 grams in the A option, you multiply it by 4 to get the calories, and you divide it by 3,678, you get 45%. So this definitely is ruled out. This is not correct because it's actually 50 to 60%. So let's move to the next one. 460 times 4, divide that by 3678, and you get 50%. So B definitely is an option for carbohydrates. Let's check out 549. 549 times 4, divide that by 3678, and you get 59.7%. So 549 is definitely the upper range. So that means 553 is out, and that means 598 is out. So really the decision is between B and C. So let's look for the monounsaturated fats at 42 multiplied by 9. Divide that by 3678, and you get 10%. So that clearly is under the minimum of 11% that we've learned earlier. So that brings us then to the MUFAs at 53 times 53 times 9. Divide that by 3678, and we get 12%. So MUFAs are definitely over 11%. They're less than 20, so that's good. Polyunsaturated fats at 37 times 9 divided by 3678, and that gives us 9%, so that's good. The polys are all right. What about at 123 grams of total fat? 123 times 9, divide that by 3678, and we get 30%. So that's actually quite correct. And cholesterol at 185, that is also correct. It's supposed to be less than 200 milligrams. So the correct answer here is actually C. This concludes the presentation. So now I encourage students to do problems that are similar to the ones that you encountered here, and I'd like you to refocus your memorization on table 4.1, which are the characteristics of the DASH diet, table 4.2, which are the blood cholesterol and triglycerides, and knowing those cutoffs, and also on table 4.3 for the TLC diet. It would also be very good to consider the different case studies that are in the textbook, and to review the blood biochemistries and the cutoffs that define patient risk.